Beautiful. Welcome, everyone. We'll just give everyone a few seconds as we begin. Just to let everyone know that we will be recording tonight's session. All right, so good evening, everyone. On behalf of Eastern Melbourne Primary Health Network and Banksia Palliative Care, I wish to welcome everyone to the Delirium and the Use of Sedatives in the Community webinar. My name is Sonia Mbezi, and I am the Palliative Care Program Facilitator here at Eastern Melbourne Primary Health Network, previously working as a physiotherapist in palliative care for over 10 years. Now, before we begin, I'd like to start with an acknowledgement of country. Eastern Melbourne Primary Health Network acknowledges the Wurundjeri people and other peoples of the Kulin Nation, whose unceded lands our work in the community takes place. We pay our respects to Aboriginal and Torres Strait Islander cultures and to elders past and present. EMPHN is committed to the healing of country, working towards equity and health outcomes, and the ongoing journey of reconciliation. We recognise and value the knowledge and wisdom of people with lived experience, their supporters and the practitioners who work with them and celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution that they make to the development and delivery of health and community services in our catchment. Just some quick housekeeping. All attendees will remain on mute throughout the presentation. Please type any questions for our speakers in the Q&A box at the bottom of the screen. These will be answered throughout, and if time permits, we will speak to some of these at the end of the session. So just a little bit about the primary health networks. The Australian government established primary health networks to increase the efficiency of medical services, reduce fragmentation of care, and improve health outcomes for everyone, especially for the most vulnerable. The PHNs achieve this goal by improving access to existing services, commissioning services to improve health outcomes, and supporting GPs and others to innovate and further improve local healthcare. We aim to improve the health of our community by ensuring people receive the right care in the right place at the right time. So tonight's presentation. GPs will develop valuable skills and knowledge to equip them to engage in meaningful discussions surrounding the management of delirium within the community. Furthermore, GPs and health professionals will gain increased confidence in the judicious use of sedatives, working collaboratively with the Community Palliative Care Service to enhance patient comfort and well-being. And now to introduce our wonderful presenters. Dr. Chien-Che serves as a palliative medicine specialist consultant across various hospitals and community palliative care services in Victoria, including Banksia Palliative Care. Additionally, he practices as a general practitioner on Saturdays. His unwavering dedication lies in supporting individuals with progressive incurable diseases to enhance their quality of life amidst the challenges of illness and end-of-life care. Chen's commitment extends beyond clinical duties. He tirelessly works to enhance community care through both his clinical and administrative roles. Moreover, he actively engages in teaching and mentoring medical students and specialist trainees, fostering a culture of academic excellence and compassionate care across all clinical environments. Wendy is a registered nurse with over 30 years' experience, with a significant amount of that time being spent as a community palliative care nurse. She is currently the training and development consultant at Banksia, responsible for internal and community education. Wendy is passionate about best possible palliative care outcomes for people living with palliative limiting conditions. Dr. Bonnie Liu is a palliative care physician and geriatrician with experience working in various hospitals and community settings. She currently works with Banksia Palliative Care and Austin Hospital. She has an interest in community-based healthcare and endeavours to support patients in their transition through different healthcare settings and illness trajectories. Bonnie is also involved in teaching and supervision of medical students and doctors in training. And lastly, Crystal. Crystal is a registered nurse for over 20 years and a nurse immuniser for 15. She is passionate about public and community health, education, and communicable diseases. Crystal has gained experience in varying positions through her career, ranging from aged care, humanitarian aid work, and the COVID-19 surge workforce. She currently works with Eastern Melbourne Primary Health Work as a Healthpathways program specialist. Wonderful. So that's all from me and my introduction. I will now hand over to Bonnie to present to you all.
Thanks, Sonia. Evening, everybody. Just bear with me. Sorry.
That's okay. How are you going, Bonnie? Do you need any help?
I think I've got it now. How's that?
Looks good to me.
Sorry. It's a bit clunky when working with
No, you've done
multiple
well.
screens. But thanks, everyone. And thanks, Sonia, for the introduction, especially and including our topic tonight, which is about delirium and the use of sedatives in community palliative care. And as Sonia mentioned, I've got Chien as well as Wendy, who will be part of this presentation as well. Just some acknowledgements before we start to our CEO, as well as Annie from Banksia Palliative Care, as well as the Eastern Palliative Care team, and of course the Eastern Melbourne Primary Health Network, Sonia and Meg, who are here tonight. So a bit of an outline of what we're going to discuss tonight is a bit of background and delirium, clinical features, why does it happen, these screening tools and management, and hopefully we can have a little bit more discussion about terminal delirium towards the end. I imagine many of you may already be familiar with delirium and some of these some of the theory behind it. So hoping I can skip through, but you will have access to the slides after today. So as we know, delirium is a serious acute medical condition, can develop over a very short period of time, and it does affect a person's mental ability. There is the DSM-5 criteria, which, simple A, B, C, D, E, and it's really focused on disturbed attention and awareness, and it can fluctuate and differs from baseline, and there is disturbance in cognition as well, often we can find a cause, but sometimes we don't. And you're probably familiar with this table with the differentials for delirium for the 3 Ds, which is delirium, dementia, and depression. And the main things for delirium is really, as compared to the other two conditions, is the onset, where delirium tends to be more acute, subacute, alertness, where it fluctuates and people can be hypervigilant, and that fluctuation in attention as well is often impaired, and thinking can be disordered, disorganized, distorted, slow, and sometimes incoherent. And delirium is important. Unfortunately, it is common, and it's not normal. Prevalence varies depending on which study you look at, and it's probably underreported in a wide range of settings. And it impacts the patient, the family, those who care for them, and it's the overall healthcare system. It can be quite frightening, humiliating for those who patients who do have a bit more insight into what is happening. And it does result in poorer outcomes as well, increased falls, pressure areas, length of hospital stay, mortality as well. And actually, if someone has persistent delirium, it can predict, it does predict an increased risk of dying as well. And that post-traumatic stress disorder, especially those who have insight once their delirium does resolve, if it does resolve, and that future risk of developing dementia as well. And for the family and the families or their close carers, where it is, they also have can experience distress and uncertainty as they're not sure, what is happening, and that responsibility of the patient themselves is no longer able to make decisions for themselves. They have to take on that role too. So that's an additional pressure. And I guess for health professionals too, especially if delirium is under-recognised, then it can impact on how we manage patients. So what we might move on to hopefully highlight some of our discussion points for this evening is a case. Is a case, and we're going to be talking about Harold tonight, who's a 78-year-old gentleman. He's based on patients that we have looked after in the past with community palliative care, and so for Harold in particular, for this scenario, the Community Palliative Care Service is contacted by his wife, reporting that he has been more confused, especially over the past week, agitated and verbally aggressive at times. And this is on a background history of metastatic pancreatic cancer with liver metastases, and very much for best supportive care where there's no further disease modifying treatments. His other history includes diabetes, heart failure, macular degeneration, and he is hard of hearing and uses bilateral hearing aids. So I guess what I would hope we will do next is I was hoping to hand over to Wendy just to discuss, because these calls would come through, say for example at Banksia to our desk nurse on the day. They would get the call from the wife, and Wendy's going to talk about how we would approach it from that perspective. So I'll hand over to you, Wendy. Thank you.
Thanks, Bonnie. Thank you. It's quite common for our desk nurses to receive such a phone call, and when we receive these calls, we have to be very, try to be very calm. Well, we are calm, but sometimes the person on the other end is not so calm. They're quite stressed. And so we just go through what's been happening in that past week. If there's been any changes, has there been any medication changes? We will ask questions about urine output and bowels and eating, and also ask whether, maybe Harold's got a fever. Sometimes that can, it could be an acute cause of a delirium. So when we go through, we do ask all those questions, and we find that there is nothing obvious. So we escalate what we call as a BRAT. It's a Banksia Rapid Assessment Tool. And that's when we would, it's an unscheduled visit for the day. So a nurse would be diverted on the road to go and visit and help attend the home to go and assess Harold and his wife. Thanks, Bonnie.
Thanks, Wendy. And so we'll just move on to a little bit more theory about delirium. And again, you're probably more familiar with the subtypes and clinical features. And from the case that, from Harold's case, we can tell that he does have a few clinical features of delirium. He's disorientated. It's an acute onset of confusion, and there's also description of agitation and restlessness as well. Probably a majority with delirium subtypes, it's mixed, and hyperactive is the type of delirium we often easily recognize when people are restless, they're agitated, they have repetitive behaviors like plucking at the sheets, or they're wandering and they've got hallucinations, and they can be verbally or physically aggressive. And probably, less recognizes and easily miss are those patients who have hypoactive delirium, where patients do appear a bit more quiet, withdrawn and lethargic, and sometimes they can be misdiagnosed as having depression, and people with hypoactive delirium tend to have worse outcomes. I guess the question we all have is, why do people have delirium? Like, why does it happen? And it's very much, there's a lot of theories, hypotheses about why it happens, and it's a combination of neuroinflammation, oxidative stress, and neuroendocrine abnormalities involving cortisol, glucose metabolism, and neurotransmitter dysregulation, with, for example, increases in dopamine, noradrenaline, glutamate, and I think in the end there's lots of mechanisms proposed, but I don't think we still don't fully understand it. It's multifactorial, and that's where it makes it very tricky, where there's no single pathway. So there's no real, single medication we can use to target it. And it is a bit of a complex interplay as well. And this is how I often think about delirium, about with predisposing and precipitating factors. And precipitating factors are probably that area where we can look at seeing whether it can be reversible. And as Wendy talked about, when our nurses are assessing patients on the phone, when they're talking to carers, they're going through, is there something acute happening with a fever? Is there an infection? Has there been any medication changes, etc. And with palliative care, especially with our patients who do have a malignant diagnosis, there are additional risk factors that potentially are modifiable. For example, if hypercalcemia, like metabolic disturbances, or other non-modifiable factors, such as someone having liver metastases and they become they go into liver failure, or if they have or the other thing that is potentially modifiable are medication. So a lot of patients who are undergoing treatment have they are on corticosteroids. You probably see a lot of people being on dexamethasone, and we're also culprits as well. You're prescribing opioids and benzodiazepines, and also other psychotropic medications as well.
Sorry, Bonnie, we just have a request if you can speak louder, if that's okay, or maybe closer to the mics. Yeah.
Sure. Sorry. Can you hear me a bit better?
It's okay on my end, but I think maybe closer to the microphone would be good.
I've got the mic on my headphones.
Oh, okay.
I can't go closer.
Okay, great.
But I'll speak louder. But if you can't hear me, just let me know. Sorry about that. But I was going to hand over to Wendy anyway, to talk a little bit more about Harold.
Thanks, Bonnie. So the nurse has gone to visit Harold and has found, with discussion from his wife, that over the past week he has become more weak and is resting most of the time in bed. She's noticed that there is increased agitation and he is becoming verbally aggressive at times, which is not normal for him. He's not eating and drinking as much as usually and is just finding it difficult to take his medication. Hasn't noticed any issues with constipation or urination. You can see his medications are listed there. He has a fentanyl patch and pregabalin. The nurse has noticed that he has increased with more jaundiced, and he's having some abdo tenderness and fullness. So there's a few things that are changing over the past week, and that would indicate some deterioration and most likely disease progression. So from there, we would call the GP. Our GP is always, or the client's GP is always the first port of call, to discuss what's happening and give them an update and try and talk about future options in regards to medications and get what we call SOS medications in the home or emergency medications in the home, and that would be the injectable medications. If possible, we would also ask one of our doctors if they're available and working at the time to also visit Harold and assist with assessing Harold. So that's what we would try to do as part of our BRAT system and escalating Harold's care. We would also get the social workers involved to assist Harold and his family. Thanks, Bonnie.
Thanks, Wendy. Let me see. I'll just try. Just going to try a different microphone. Is this okay? Can you hear me better?
That's really clear, Bonnie. Yeah.
Yeah, no worries. Sorry about that. So thanks, Wendy, for going through that case. And before we just go through the next part of when our staff, nursing staff, or goes out to assess our patients, how what sort of screening tools might be useful. I'm not sure if people have heard about this squid. I find it very simple. One question: do you think Harold has been more confused lately? And it really improves that early recognition and awareness of delirium. And so that usually is the first thing we probably do subconsciously anyway. And you're probably familiar with the CAM, the confusion assessment method, which is developed by Inui's group in the early 1990s, and it's got 4 main criterias: acute onset and fluctuating course, inattention, disorganized thinking, and altered conscious state. And the CAM, delirium basically is if features of 1 and 2 are present, and either disorganized thinking or altered conscious state is there. And I'll be interested to know from the audience, have you used these tools as well, and how you found them? NewDesk is another screening tool that is studied or used in the palliative care setting, and very much there are different criteria or symptoms, and a score of more than 2 identifies the presence of delirium, and it can be done in different shifts, so usually in that inpatient setting. Probably the one I like from more also Jerry's, but also from a palliative care perspective, is the 4AT. I find it quite simple. It's quick. You don't really need much training for it, and it also it allows for the testing of untestable patients. So the people who have hypoactive delirium, who are quite drowsy. And so basically score 4 or more is possible delirium. And that's what the scoring sheet looks like. And there has been a validation study for the use of 4AT in patients receiving palliative care in that hospital inpatient, or for this study it was in a hospice setting, and that was positive when they compared it to the reference standard, which was based on the DSM-5 criteria that was at the start earlier on in the presentation. So we'll go back to Harold again to talk a little bit more about his progress. So thank you, Wendy.
Yeah, no worries. So it does appear that Harold has a bit of a mixed delirium with no reasonable understanding, as in no understanding as to why this is happening. Harold's wife, Judith, is his medical treatment decision maker, and the goals of care in his advanced care directive has stated, and these discussions have been had, that he values quality of life with independence and only wants treatment that can maintain that quality of life. He has stated that he doesn't want resuscitation, and he doesn't want to be, in his words, a vegetable. He prefers to be at home for his place of death with his family around him. So there are a few considerations and discussions that we have with Judith regarding his ongoing management. And I think they're on the next, if you go through the next slide, Bonnie. So there's a lot of considerations there, and it is a lot of things to consider as we are heading towards end of life, and as the situation is deteriorating. How everything is going to, Judith is going to manage. Is there an understanding that he is deteriorating, and also again talking about those goals of care, the impact on Judith, the social considerations, as in the impact of her being a carer for Harold at the end of life. And sometimes a lot of people don't really quite understand what that looks like. And then physical considerations as well. Do we need to get some equipment in the home? We need to keep Harold and Judith safe, regards to if he is walking or restless and walking, or if we give him medication that make him drowsy and increase risk of falls. So these are all the things that we need to consider when we're trying to manage Harold at home as safe as possible. So we might even hopefully would arrange a hospital bed in the home once time moves on, and any other supports that Judith would require at home. The social workers would assist with supporting Judith and the family, and also we have our enrolled nurses who give education about bedside and personal care. So there's a few things that we need to discuss and think about with managing Harold's wishes to remain at home for end of life. Thanks, Bonnie.
Wendy. And I think you're following on from that, you're talking about management of patients who have delirium, we've identified have delirium. It really depends on the stage of disease, their overall prognosis, the goals of care, and that decision making around reversibility and understanding their wishes. And I think with what we've discussed with Harold, these investigations probably wouldn't be appropriate, but there are things that we can do with the GP facilitating these, if appropriate, completing bloods, urine culture, imaging. Probably imaging will be quite challenging for many of our patients because they're probably at a stage where they're not able to attend. But it's really about that bigger picture of what is our goal here, and what are our goals of care. And if we are looking at probably not someone like Harold, but someone who is a bit more well, or with looking at goals of care, trying to find something that is reversible, we definitely look at the medications. Even for Harold or anyone, we'll be looking at medications. And the desk nurse yes, Wendy mentioned, would have asked if there were any medication changes that might have contributed. And if we're thinking that there is opioid toxicity, we can rotate it to a different medication. And if people are hypoxic, we can try oxygen, and infection, we can try antibiotics. And of course, if there's any metabolic abnormalities, for example, hypercalcemia, we can look at treating that, but that's probably more done in an inpatient setting rather than in the community. And this slide is really just saying with management of delirium, a lot of it is focused on non-pharmacological strategies, and everyone can take part in this, whether it be the visiting staff through Banksia, or the families and the carers as well. And I think very important and is about that education for family and carers who are attending to the individual patient. The next couple of slides are really just to detail a bit more about the non-pharmacological strategies, so I won't go through them in detail, but it's very much common sense in trying to, having that low stimulus environment and reorientating people, and just making sure they have easy access to their glasses, their hearing aids and dentures, and hydration where they can do so safely, and just monitoring those bowel and bladder functions. So with Harold, Wendy mentioned there was no suprapubic tenderness, so just making it's not going to be as accurate, say, as a bladder scanner, if that was available, but just assessing to make sure person's not in urinary retention, because we can definitely put in a catheter to see whether that alleviates some of that distress as well, and simple things as managing constipation too. And as mentioned, it's really about a bit mainstay of treatment is providing that support and education to the patient, but especially in the community setting, it's to the family and the carers that are helping support their preferences to remain in the home setting. So there are a few examples of what handouts are available through Dementia Australia. Someone does have a background history of dementia, but also I was having a look in the New South Wales, seems to have a really nice one about delirium as well. And so what we'll do is we'll move on. As I wonder, many people probably attended tonight, more interested about the pharmacological, management in delirium. And for the most part, we try not to use medications unless there is that severe behavioral disturbance or emotional disturbance where the safety of the individual or those caring for them or those around them is impacted. So basically assessing the risk to themselves and others. And if we're starting medication, and usually it is an antipsychotic, we would start at the lowest dose and then titrate. And also, and having a plan for follow-up of those medications, we do start to say when things do improve, what is the weaning plan, what is the cessation plan, and who's responsible for following that up. Because we all know that there are side effects with all these medications. Very useful resources, the Australian Delirium Clinical Care Standard, and pretty much saying similar about avoiding the routine use of antipsychotics for treating delirium, and having, if you can use it short term ideally, and having that follow-up plan as well. And it does state about avoiding benzodiazepines. As we do know, it can also contribute to delirium, but there is a role for the use of benzodiazepines, especially towards that end of life phase, and for those who aren't able to use the typical antipsychotics as well, such as people with Parkinson's disease or Lewy body dementia. So in regards to antipsychotics, haloperidol is probably the most commonly used. I'm probably a bit more conservative, and depending on who you talk to, it varies how we prescribe it. Right, the most and yes, and as mentioned, we do try and avoid these typical antipsychotics in people with Parkinson's disease and dementia with Lewy body, and especially in our older patients. They are at high risk of developing extrapyramidal side effects. So starting with that low dose and monitoring. And there are alternatives, including olanzapine, risperidone, and quetiapine. We tend to use haloperidol in palliative care mainly because we can access it orally as well as subcut, and we also use haloperidol for, apart from in the delirium setting, for nausea or vomiting as well. But yeah, we do recognise that with its use, unfortunately, it doesn't seem to reduce the duration, with some studies that have been looked at that. Oh, sorry. And it's really about having that, reserving the use of antipsychotics for those with severe agitation, and balancing that risk versus benefit, and having good communication with family as well as the care staff. And so this table is really just a table of the antipsychotics and their side effects as well. And I quite like it because it talks the plus signs reflecting of frequency of it happening. And you can see haloperidol, less of a sedative, but you get more of the extrapyramidal side effects compared to some of the others. So, and benzodiazepines I mentioned as well. It can, it can increase the risk of delirium when you're used by itself and cognitive impairment and contribute to falls and subsequent injury similar to antipsychotics. And in a very small proportion of patients, you can see a paradoxical reaction as well with them becoming more agitated or disinhibited. And commonly used in palliative care for delirium, we do use lorazepam, clonazepam drops, as well as midazolam as injection ampules. So we'll go back to Harold, and I'll hand over to Wendy. And I can see, can a question from Lisa, can Harold have some wine at mealtime? I think really with Harold, we're really thinking the focus is on his comfort, and really about trying to achieve whatever we do to ensure and achieve that. And if drinking wine or any other wine is what he likes, or any other alcohol or spirits, and then so be it. But I'll hand over to you, Wendy.
Thank you. Absolutely, it's about Harold's quality of life, and if that wine, or what some clients were found in the past have had a red or a whiskey of the evening, and brings them joy, that's totally okay. They're living in their home. We're not in a position to tell them what they can and can't do, to be honest. So please enjoy. So look, Harold's progress, he is heading towards end of life. So he is, and it looks like he may be heading towards the terminal delirium. And again, Judith wants to keep Harold at home to respect his wishes. So we have, along with our psychosocial support team and physio, including Carers Gateway, we've arranged a hospital bed and regular nursing visits and carer support. Judith's children and Harold's children live locally, so they can provide some informal carer support, but most of the full care is on Judith. And we do arrange those palliative care injectable medications. So that would include the ones listed here, the haloperidol amps, clonaz drops, and midazolam. That's not all of them together, but they may be options that would be discussed. And that would also include medication for pain relief and nausea for just in case, if that does become an issue with some of the pain medications. So he is heading towards end of life, and we try to preempt that things are changing and we need to get everything in the home to support them.
And I think just to add to that, Wendy, with the medications, our nursing team will probably generally try and contact GPs first as the primary care provider to see if we can help support those medications being available, and also writing orders as well. I think we showed it in the last week's presentation of just writing it up, so then the nurses can help with drawing it up and teaching the family or administering it as well. If there's ever any questions or concerns about medications that are being recommended, just let us know. Our nurses are quite experienced, and as Wendy mentioned, we do have the palliative care physicians like myself and Chien, who are available as well and very happy to chat. But we'll move on to terminal delirium, actually, and very much the development of delirium in dying patients it's a poor prognostic sign, and usually unfortunately it's refractory. and it can cause a lot of distress to the person themselves, as well as to their family and carers. And it's very much, in Harold's situation, where we've established that, further invasive or non-invasive interventions haven't really been able to provide that adequate relief, and or are unlikely to provide relief within a reasonable time. And you've probably heard of the term palliative sedation, and this is very much a specialist palliative care management approach, and it's Safer Care Victoria has a very nice guideline detailing it, that basically it's the intentional use of sedatives to alleviate a person's suffering, if they are to have experienced refractory symptoms such as terminal restlessness, which may be suggestive that they've got unresolved symptoms, whether it be pain or psycho-existential distress, and it involves a multidisciplinary team approach, and there's really no alternative treatment options available, or they've been tried and they've been inappropriate or unsuccessful. And as you can imagine, there's a lot of emotions that can be expressed and experienced with a scenario where we are talking about palliative sedation, and supports required for everyone involved, patients, the family, even the care teams, and very importantly is to have that regular updates and support. Some of the medications we do use in someone who is experiencing a term of delirium, and they're thinking they do require palliative sedation. The main classes are really benzodiazepines, antipsychotics, and barbiturates, so that we've mentioned already. And we can run these medications, if it's not useful regularly, we can run it through a syringe driver through Banksia. And some of the second line, third line medications like levomepromazine and phenobarbital, I mean, we can probably really not commonly need to use them, but one of the main limitations is the difficulties in sourcing these medications in the community, and as well as the cost. Phenobarbital is probably a bit easier to source, but levomepromazine, it's quite hard in the non-hospital setting, or without the involvement of hospital pharmacies or inpatient teams. And I think we had a patient earlier in the year where we were able to access it because they were the hospital team was able to help with the ongoing supply of it. So I'll hand back over to you, Wendy, to give us a bit of a summary of progress of Harold.
Yeah, thank you. So as Harold's deteriorated, so did his needs. His needs increased, and that did create significant carer fatigue for Judith. However, she was adamant that he was wishing to remain at home. We do give a lot of support to families in regard to sometimes, and it wasn't in this particular situation, but sometimes home is not always manageable. So then we can always offer transfer to a palliative care unit. With Banksia, we can arrange a direct admission to a palliative care unit once a bed becomes available. We pop in a referral from the office for end-of-life care, and whichever palliative care unit we have requested this, will let us know when there is a bed available, and that can take sometimes a day or two. But having said that, the carer doesn't always have to accept that bed, but it's just a kind of sometimes a nice backup. We always just explain to people that just because they've promised to look after people at home, which I know is always ideal, it's not always practical. So, and not always humanly possible. And please don't take that guilt and feel like they need to, and we're very supportive of that. And many times I've said to carers, you know, if they are getting moved to a PCU, then they can just be the loved one and hold their hand rather than the carer. So we try not to put too much of a negative stigma on that one. We support the family regardless. So with Harold, he was having regular breakthroughs, injectable breakthroughs over the next coming days. And then, so therefore, as those increased, we commenced a syringe driver with morphine, haloperidol and midazolam. And usually those medications and doses are calculated by how many breakthroughs or how many the injectable breakthroughs that he has had in the last 24 hours. And also that would have been taken into consideration his fentanyl patch and pregabalin as well that he was having. So he did become settled, comfortable and settled, and he died 3 days later. So that was Harold, and it is a lot of things to consider going through that process with Judith and Harold. And it is, again, it's the emotions that go along with the whole process and that deterioration phase. And we do rely on GPs for those ongoing injectable medication supply once that has started. So that can be quite time consuming for families. Sometimes they have to visit the pharmacy daily or every second day to keep stocking up for these injectable medications, but that's the way it is, really. So we just try and support them as much as we can. Very handy that Judith's children were nearby so they could assist with that too. Over to you, Bonnie. Not sure if you want to add something else to that one.
No, and I think just on the note with just prescribing, we do try, PBS has, if you look on PBS, it's quite, as for some of the medications like morphine, buscopan, it's easy, you can have, there is the palliative care streamline number, so that does make it easier to get the higher repeats without having to call up or apply for PRODA to get more quantities. But a bit of a summary. So we've covered a lot tonight, and hopefully, through the case of Harold, you've been able to appreciate the complexities with managing someone who has delirium and who and we're trying to support them and their family for them to remain at home for end of life care, and also being aware that we know delirium matters because it does cause distress to everyone involved. It impacts on their prognosis, and very much guided by goals of care and your disease trajectory and prognosis to guide what our approach to management, with whether it is through further investigations or is our main focus on symptom management. And it's very much, delirium management is interdisciplinary approach, and a combination of non-pharmacological interventions as well as medications when the person is at risk to themselves or others or in insignificant distress. And the main medications are the use of antipsychotics and benzodiazepines. And as Chien said, unfortunately, it doesn't change that course of delirium. It doesn't shorten it, and sometimes we know it can add to adverse effects as well as mortality as well. And finally, terminal delirium. It's a poor prognostic sign, and if we're ever considering palliative sedation, especially for people who have uncontrolled symptoms of distress, then it's again very much an interdisciplinary approach and a specialist palliative care management as well. So thank you, everyone. I've just got a couple more slides about how to refer to community palliative care. So for Banksia, anyone can refer, and the referrals generally come through the website. There's a form that you can complete, or by telephone as well if it's more urgent or if you're unsure. And then there's also other services available that you might have heard of. There's the Palliative Care Advisory Service, which is statewide, and the person doesn't need, and anyone can call up again. And if it is for about an individual person, they may not already have palliative care involvement, and they can support with linking in with community palliative care services if appropriate. And there's also hospital-based palliative care services as well. And if you are attending tonight and outside the Banksia catchment, there is Palliative Care Victoria, the website. You can look up the service provider near you as well. And obviously, the other thing not to forget is for our palliative care patients, it doesn't mean they can't access your trials. There are trials available, especially for those who are linked in with community palliative care services. So especially focusing on symptom management and improving that quality of life as well. So don't ever forget that. And I think Chien's answered the questions as we've gone, but I think that was all we had from tonight from our end, and I'll hand over I think to Crystal.
Thank you so much, Bonnie. Hopefully we've got that up running on the screen okay there. Thank you very much for inviting me to be here. My name is Crystal Bervego. I'm the program specialist at Healthpathways Melbourne.
Crystal, you're very quiet. Could you just possibly move your mic?
My apologies. Sorry. Thank you. End of the night, so I'll try and make it quite quick so you guys can all head off. Thank you, Wendy and Bonnie. That was a great presentation. So look, in the limited time I have with you, my goal is to demonstrate how Healthpathways Melbourne can be a fantastic resource to access the information that you require as quickly as possible at the point of care with your patients. Healthpathways Melbourne is a collaborative online resource developed by Eastern Melbourne and Northwestern Melbourne Primary Healthcare Networks in partnership with healthcare professionals and organisations in the Melbourne region. It provides clinicians with a comprehensive collection of locally relevant clinical information and guidelines designed to support general practitioners and other healthcare providers in delivering consistent and evidence-based care to their patients. Today, I'm going to look at delirium and the use of sedatives in palliative care and help you navigate through our pathways. Okay. Okay, here you can visit the Healthpathways website and log on. You can see the latest news and pathway updates. You can find the pathway you're looking for using the table of contents or using key terms here, as we've chosen with delirium. Today, the pathway that we're going to use is delirium and terminal restlessness. First, I'll just draw your attention to that clinical editor's note at the top of the page there, which will take you to the PCAM. And I've also got the medications involved there as well in the PCAM list. Moving on. Sorry, we jumped ahead there. My apologies. As we travel down further on the page, you'll find the assessment section, which provides a concise list of steps that clinicians may consider taking to diagnose and evaluate the severity of a patient at the point of care. Drop boxes throughout the pathway will provide supplementary information. And I've highlighted here causes of delirium, progressing further down the page, we have the management section, again, providing additional succinct list of steps that users may consider taking. Highlighting here goals of care, and very important link out to advanced care planning, which will take you to our advanced care planning page, which will provide you with all the documents that you require there. Returning to our original page, as we travel further down, just wanted to highlight a few things that were discussed today, like the non-pharmacological and also pharmacological treatments. Things like anticipatory prescribing of haloperidol, we've also got links to the therapeutic guidelines here, highlighting sedation in the agitated patient. Further down, we have our referral section. Here, we're going to take you out to a palliative care specialist services page. Here, you can find private and public links. Under the public section here, provide the criteria required and specific to the regions. And here you can see Banksia Palliative Care Services that will provide you with all of the referral options. Returning back to the original pathway, we can find an information section at the bottom, which has just further information specific to health professionals and patients. The next 2 pages, I have just provided a list of relative pathways. We have over 40 pathways in the palliative care suite, which have recently been updated. Oh my gosh. There we go. Accessing health pathways. It's available to general teams and other health practitioners in the Eastern Melbourne and Northwestern Melbourne PHN catchment. To access health pathways, you've got the QR code there. Alternatively, you can send us an email at info@healthpathways.melbourne.org.au. Thank you everyone for your time.
Thank you so much, Crystal. So thank you everyone for being part of tonight's session. It's been a pleasure to have you all here, and I hope you've taken away some valuable insights about palliative care. I'd also like to extend a special thank you to all of our presenters who have done a great job in teaching us a little bit more about delirium. By participating in tonight's RACGP event, you will be accredited 1 hour of educational activities, which I will lodge on your behalf for all GPs. So that we can further improve these education workshops, please take a moment to fill out the event survey, which you can do by scanning the code on the left of the screen. At the end of the session, the link will also appear, and all of your responses are really highly valued so that we can continue to improve and target our education for you. If you haven't already done so, please register yourself for the next session of the series with Banksia Palliative Care, and that's conducting essential conversations with palliative patients and their carers, which I know from last time I really enjoyed that session. It's being held on Zoom on Wednesday, the 1st of May at 7 p.m. There will also be a follow-up email that comes out for everybody, and you'll receive a copy of the presentation from tonight, as well as any other relevant resources. You'll also receive your certificates within the next 4 weeks of the session from EMPHN. Thank you all for your time tonight and attention, and I hope you have a lovely evening, and we look forward to seeing you next week. Bye for now.